Does depression really get worse at Christmas time or around the holidays? And I'm going to direct that question to Dr. Arbaugh.
Well, I think that we have to look at depression as a chronic illness. It tends to be worse during the darker months of the year. And we're seeing that already in the office. A lot of our patients are complaining, the depression's worse because, it's darker in the morning, it's getting darker sooner in the evening. So depression tends to be worse, during the fall months and early winter months. The problem with Christmas is that Christmas in and of itself doesn't really make depression worse, but is what does happen is the fact that people get kind of stressed with Christmas. There's the financial stresses. Oh, I got to get this done. I got to get that done. We've got, these parties to go to. We got to get ready. We got, 20 people coming over for dinner. And I think people take on too much. And so people who are already depressed, it does kind of drag them down a little bit. So, yeah, that is a stressful time for people who have depression.
I'd like to actually go to the fact when it comes to our elderly population, the expectations change, and the fact that they may not have those people in their lives in order to be able to spend their holidays, etc. Or we live in a society where my son has a job in Seattle. He doesn't have a job in this particular community. So those things, the life has changed and the way they celebrate those holidays changes. So isolation is intensified in a season of the year where the expectation of the Hallmark movie is that we're all going to be having cranberry sauce together.
Yeah.
Right.
And that doesn't happen.
Right.
Right. And we do see that quite often in our population that we treat. So one of the questions here is, does the amount and length of trauma experienced in youth translate to greater risk of experiencing depression when you're older? And I'm going to send that over to one of our therapists. Chris, can you answer that? Give some info on that?
Well, I would say if the trauma wasn't addressed as a child, a lot of times individuals get stuck at that age. So if they're just now talking about it at age 70, it gets a little more difficult to sort through. So I would say yes.
And how about Dr. Arbaugh? Do you have anything to say on that too?
Well, the thing I would like to add is that there's data that's come out in the last 10 years or so because, we've struggled with this in the mental health arena for a long time. What really is the effect on abuse, particularly repeated abuse, long term. And for a long time, we really didn't know. People had, their thoughts about it. But it's very clear now that it does affect the neurocircuitry in the brain and that change in the neurocircuitry is actually permanent. One of the things that we see that we never really could explain is why do a lot of patients who have been abused, they tend to rock. They'll do this kind of thing when they're sitting, or they tap their leg at a speed that I can't possibly do. And it all has to do from changes in the neurocircuitry in the brain. And that's what's responsible for those kinds of things.
Okay. I have a question here about how would an individual's doctor know about any medication changes if they were part of our program? And I'm going to send that question over to Nikki.
Okay, so my job there is to, be in contact with everybody's PCP. So after they have an appointment with doctor, I, the next day or that day, follow up with them and ask them any changes of medication, frequency of therapy, or any issues that, we've noticed while they've been treated with us. They might come to me with medical issues where I have to refer them back to their PCP. They're constantly coming to me with various issues that they might have going on. So I just always keep in contact with their PCP office.
Okay. There's another question. Oh, I got another one up there? Okay. Fabulous. Okay, I've got another question here. Whoops.
Let me move back just a little bit in case you need to get through.
Are there difficulties differentiating depression when your hearing loss is maybe a factor? And I'm going to start with Dr. Arbaugh on this, and then I think my therapist can jump in on this too.
Well, I certainly can see where, when somebody loses the ability to hear what's going on around, they do start to disengage from things, and, certainly that could be I think one could make an argument that that could, be a stress for depression in those individuals, who are vulnerable. But in terms of actually making the diagnosis, it gets back to the DSM, it gets back to the criteria. It's all about the criteria. And, that's what I do as the psychiatrist is, I try to determine whether or not they meet the criteria for the illness, and then I can make that diagnosis, and then we can treat the patient appropriately.
Okay. Anything more that the therapist, when it comes to somebody having multiple losses, anything we might see?
Certainly. Well, first of all, grief is natural. If you have, a connection with a loved other and you lose them, loss is natural. But as the, folding into what the doctor said, it is the intensity, how much it affects the different areas of their life, and the duration that this is occurring. If a person has multiple stressors, of course, they're going to have an intensified result. And with loss, you have life change, so therefore the ways that you used to live your life are no longer continual. Especially, this happens again and again with men in our program. The wife made all the social arrangements. The wife is no longer part of that. The husband never developed contacts by himself, nor is practiced in the skills of creating a social environment for himself. So as part of therapy, one of the things that we try to teach is some type of social initiation skills or ideas how they might be going ahead and being in an environment where that might be a little easier.
Okay, we've got a question here. How long does it take medication to work, Dr. Arbaugh?
2 to 6 weeks if it's going to work. If it doesn't work by that time, then we generally make a change.
Okay. And should a person stay on medication, or should they go off it when they're feeling better?
They should stay on it. Do they go off of their blood pressure medicine because their blood pressure is better? Do they go off of their insulin? When their blood sugars? I should hope not.
But we know that does happen. Okay.
Barney Hassel's.
I don't.
Dr. Faber.
So
Oh.
I got a couple questions. Are we all born equally well? Our scientific MRI stands for the same hippocampus percentage in our brains. That's one question. The other question is, we hear about our nation as a whole becoming less faithful, as I should say. Where does that religion play a role in this? Because it seems like depression has increased the more we get away from some set of beliefs in that sense. So those two things. One's kind of an image thing. Do we all get the same fair shot at a hippocampus? And if we're never depressed, does that mean our hippocampus might be bigger?
Well, I'm not aware, first of all, of any studies that have actually been done, because you would be scanning people before they had depression, and we've only looked at depressed patients, but these have all been double-blind, placebo-controlled studies where the control group has been very well matched, by age and so forth.
I thought that was the answer.
Yeah, so I don't really know. I mean, intuitively, since they're not born depressed, even though they may be genetically vulnerable, I doubt that we would find any changes in hippocampal or prefrontal cortex volumes. I doubt that we would see that. As far as the second part of your question about, the role of religion in depression, let me say a couple of things, but then I'll defer to the therapist. I think that there is data out there that shows that people who, do have strong religious beliefs, that they attend, some kind of church, that these people do tend to be a little bit better adjusted, and they tend to fare better for the long haul with depression. So that does seem to be some kind of a stabilizing factor emotionally, at least. I don't know, Dave, do you have any comments on that?
I was saying if you're going to get out of the house, going to Bible study or church, it's going to decrease the isolation. There's going to be more activities, and so that helps too.
One concept I go is that I believe the human being was meant for socialization, to be in groups with other people. And I would tell patients very often, you know what? Let's not care if you believe to begin with. It is a community of supportive people who have routine events that, that maybe have low pressure and is organized usually around hope. Sounds like a pretty good place to be, doesn't it? All right? Mm-hmm.
And my training is actually in pastoral counseling. So it looks at the person as the whole mind, body, spirit piece. And I think that, and by no means do we tell people how they should think or believe, but I think that as people find that grounding piece, that there's something larger to them that helps give them that piece of hope. And like Chris says, and Dave, it's that connection. People are longing, and the people that we see in treatment, they are so longing for those connections with people. So I do think that is a huge piece for people, however they find it to work for them. Okay. The success rate of somatic therapy in elderly. And then the question mark, is it covered by insurance or seen too extreme for their age?
Well, as far as the somatic therapies, it is covered nowadays by most insurance. The magnetic treatments, up until recently they weren't covered, but now most of the insurance companies are doing it. The nice thing about those is that people go for these magnetic treatments. Most of them, they wear a helmet, and the magnets do their thing. They put them over the parts of the brain that are associated with depression, and it's about a 20-minute thing. Patients will go 5 days a week for 6 weeks, and then they have kind of a ramp down where they go once a week for, I think, 4 weeks, and then every other week for the next 2 months. And yeah, those are definitely covered. Electroconvulsive therapy is also covered. It certainly is not too extreme. In fact, ECT is probably one of the safest treatments. The only real risk with shock treatments is the risk of general anesthesia, and that risk is fairly minimal. So, yes, the somatic treatments are utilized in older patients.
I will say availability, though, is another issue. The doctor has already talked about people having travel at a distance, and if you've noted a person is having 5 days a week of treatment, well, that's very prohibitive for somebody who lives in a rural environment such as ours. Why might somebody, that's an important question to me, why might somebody be referred to some of the somatic treatments? Is there a criteria before?
Well, the truth is that when you really think about these things from a medical point of view, you can argue that they could be first-line treatment. The problem is that they're awfully intrusive. I mean, going for shock treatments and getting general anesthesia, that's a big deal. Even having to go every day, even for 20 minutes, is kind of a pain in the neck unless it's just, a couple blocks away and you're retired.
Right.
So, the reality is that most people are going to respond to medication. So we're going to treat people with medicines first. But at some point, if we decide, that this person is going to be resistant or refractory to treatment, and they're, a TRD, a treatment-resistant depression, then we start thinking about, more aggressive pharmacotherapy, but we also start thinking about the somatic therapies at that point, particularly, the ECT and the TMR.
Okay.
Thank you.
Another question here. How does the referral process work for our program? And I guess I'll answer that because that's a part of what I do. We would get a referral it could be from any of you in this room. It could be from the patient themselves. It could be a family member. The piece that we always want to make sure that happens is that the individual knows that we will be contacting them. We wouldn't want them to be getting a cold call, which could increase their anxiety and just wonder what the heck's going on. Then what happens is I usually would set up an appointment with them. Oftentimes I'll go to their homes to do the screening, or they can come to our office. The screenings take a little over an hour. We ask lots of questions about what's currently going on. We get a history, psychosocial type history. We also then will do some assessment tools where we do the Hamilton Anxiety Scale, the Geriatric Depression Scale. We do mini mental status exams and clock drawing to make sure that cognitively and physically they're able to manage to stay in our, be able to learn and receive the information that we're going to give them in treatment. And then what happens is if they say they want to go and they meet criteria, then we set them up to see Dr. Arbaugh, and we do use telemedicine as a way to reach him. Nikki sits in with him. And from that, then we determine the length and intensity of their services. And so I'm going to turn over to my therapist, what would be a typical day that would look like at Senior Behavioral Wellness?
Chris.
Well, patients arrive either by the van or they drive themselves in, and we do 3 groups. The first group's a process group. They fill out a check-in sheet, and I'll have them rate from 1 to 10 pain, anxiety, anger, and depression. It also asks side effects of medicine, if they're having any side effects, if they have any suicidal or homicidal ideation or thoughts. So the first group is 50 minutes. We go around, check in, how are you doing? Have they used any of the coping skills that we've been talking about? Struggles they might have, and then we take a break. We run into another 50-minute group. It's a cognitive group, talking about how they can change their thoughts and thought patterns. Are these thoughts productive for you? Are they negative thoughts? Can you replace those? Then we have lunch. Then we run into our third group. It's a behavioral group, talking about what changes you can make, what behavioral changes you can make to put into action something different. And then get on the bus and van and go home.
Now, also to add to that is that the patients will always have new circumstances. The therapist's job is to go ahead and say, what's kind of the theme that's going on here? And also, every single patient has treatment objectives. So we're trying to go ahead and say, what's evolving with the patients, what seems to be common, what works best for the patients, so we can funnel to say, okay, what is the particular thinking error the patient is using right now? What is a lifestyle change that is as the most part might be something that is acceptable or beneficial for the patients? So we don't go in the morning and say, well, in the second group, I'm going to go ahead and talk about personalization, and in the third group, we're going to do gratitude journaling. So we have to be improvisational, shall we say, about how the day is going to take place. And also, not everybody speaks for 5 minutes. Somebody might speak for 5 minutes, but somebody might have had a trauma yesterday. And that could drive a lot of things too.
Right. So our major modality is group counseling, but we also do individual sessions. And like Dave said, we don't do set programming. We find the common thread that's going through that first group for the day, and then we run with a topic that's going to help those group members that day. I've got another question here. Is the 2 times higher rate of major depressive disorder in women clinical, or is it part of a problem of a person not seeking help?
No, it's a genetically mediated thing. People like to joke and to say it's because women have to live with men, and men say that we're twice as likely to be alcoholic because we live with women. But actually, while that's humorous, the truth of the story is that really is genetic. And what how that all pans out, we really don't know yet. We just know that from all of our epidemiological studies.
We also look socially, is that women are more likely to speak with groups of women about their feelings and the way they're thinking. So let's think about this, is that if you naturally have a group, at least in the social construct, not everybody does, where you're going to go ahead and at least talk about the way you think and feel. It is not traditionally, especially for our people that we work with, is not traditionally how a senior male deals with those emotional issues. Now, how much of that presentation is, and if we're going to look at the study and being a social worker, that the man actually goes ahead and presents and says that he has those things that are those emotional reasons that are interfering with his life.
And so, hence, the group setting, it's a safe place where they can learn to use those skills that maybe they've never had before. So, they also learn from each other, and they also affirm each other. So, do I have any other questions from anybody?
I have one. So as you encounter folks, or even in your own family, and you're concerned, like they could be depressed or not, you can't diagnose someone, how might you all suggest you start that conversation with that person or your family member?
I love using two particular catchphrases. One of the things is that you don't want to tell people that they have a diagnosis and they have a problem. You want to help people discover things. And the phrases I like to start with, and we also learn these things in our therapy, I've noticed and you've seen.
Yeah, or I'm concerned. Sometimes I'm concerned is a good one.
When you know, so first of all, learn some of the warning signs, and there's lots of literature out there of what depression is. And remember, we also talked about presents a little differently for the senior population. Actually presents differently for children, people in the middle ages, middle ranges, and for seniors. We in fact have completely different instruments to diagnose those things for those things. But I've noticed, talk about some of the behaviors, and you've seen. It gives the opportunity for the person to go also say that, oh, you're incorrect. What I really is this. Mm-hmm.
The other piece to that too is you can, like I said, you can use the I'm concerned. How long's it's been going on for you?
Yes.
Have you talked to anybody about it? And the biggest thing you don't want to do is try to tell them that you know what they're feeling and thinking. But
Yes.
those are some openings that you can use, and you'll probably get a lot back from them with those openings. Any other questions?
So are you guys finding the same trend as far as the patients who come in to see you guys as far as it being primarily the female population over the males? And the kind of flip side, are you seeing a big population of, as us in nursing homes, sometimes we get stories of patients from the hospital that we just hear that, we just don't want to go to the nursing home. Are you guys finding those same kind of things? They just don't want that help, and you're finding they're not continuing to go back to get more services? Maybe they meet with you once and don't come back.
I would say a patient typically, even with resistance, if they have gone to the point where they've accepted that I'm going to try group therapy, I would say about 90% of them after a singular day of group therapy are like, oh my gosh, I can't believe that I didn't do this. Right? And any gender. All right?
And some of them are very resistant. When I bring up the word group therapy, it's like, they just get, I can't talk to people. And usually it's usually just the way, I try to work with them to say, just give it a try. Other people have experienced it differently a little bit in their life during what you're experiencing, but there's still a lot of common threads. And usually if I can get them to come to the first group, usually then it's share at your own speed, and they recognize that that's that safe environment. They do usually come back.
But separation, yes, we do have mostly females. But
our census is...
But our census for males has really changed, has really grown. Yes.
And just to add in there, I do think that we see a lot more women in these programs than we do men. But you also have to remember that we're not just taking from the general population. We're getting referrals from nursing homes and hospitals where you're already at a much higher risk for depression. And that's probably what accounts statistically for us having more men than you would predict by taking, half of the number of women.
Women live longer.
Well, that's also
I had
true.
a patient is like lives in senior housing. He says, so why are there so many women here compared to men? I said, well, let me tell you about mortality.
Any other questions before we close up? We got one more here, and then we'll... Is there a point where medication that used to work doesn't work, and if so, why might that happen? Why might it stop working?
Well, the answer to your question is yes, but let me qualify that a little bit. First of all, most of the time when somebody's been doing well and then they're not doing well, it's not because the medication quit doing whatever it is that it's doing. It's because the illness is acting up. This is a chronic illness and it acts up. Let me give you an example. Somebody has diabetes. Well, today your blood sugars might be horrible and you did everything perfectly yesterday. Who knows why that is? There's some variability with all of that. So the antidepressants, generally don't quit working. The illness tends to get worse. And is what we need to do in those cases then is we either need to increase the dose, or sometimes we use combinations of antidepressants that have different mechanisms of action, just like your doctor may have you on a couple different blood pressure medicines to try to get a better response. Now, having said that, the literature does support, we call it, and the literature uses the term Prozac poop-out phenomenon. And, the technical term is tachyphylaxis, but Prozac has been shown to lose some efficacy over time. But again, when that happens, it's usually rectified by increasing the dose or adding something to it. But generally, it's not that the medicine quits working, it's that the illness is acting on